Thank you very much, Sam, and welcome to all our attendees this evening. It's my pleasure to do the introduction this evening and welcome you to this ethics and scientific session put on in association of the association along with Medimpex Jamaica Limited. This topic, the topic of this evening, whether the vaccine should be mandatory at the workplace. We thought about it significantly and we talked about it for a while. And we consider the pivotal role that vaccination is going to play in terms of our recovery out of this pandemic. But we know that there is vaccine hesitancy. So we decided that we would put on a webinar to address some of the issues surrounding vaccination at the workplace. In doing this, we sought together as wide a cross-section of leaders and influential voices in the society as possible. So we gathered, we got together, we got Professor Marvin Reed, he's the Deputy Dean of the University of the West Indies, UWMONA Medical School. And we know Prof will bring us a lot of very interesting facts. We have Mrs. Carla Ann Harris Roper. She's an attorney at law and she's also an HR specialist. And I'm sure she will guide us as to what is legal at the workplace and what are the ethical stuff that should be done at the workplace. We have the union represented by Mrs. Ellen Davis White. She's the president of JALGO, and I'm sure she'll be defending the interests of the workers and the rights of the workers throughout the discussion. We have Mr. O'Neill Grant. He's the president of the Jamaica Civil Service Association, and that is a very large body of workers. And I'm sure you'll tell us what is the pulse as far as these workers concerned in terms of whether they will accept the vaccine, whether they will revolt against the vaccine in terms of it being mandatory. We have very interesting Mr. Bradley Mafood. He's a representative from the Jamaica Chamber of Commerce, and I'm sure he'll bring the business point of view to the meeting. Now, to steer us in a discussion and keep it balanced and keep it lively, we have Professor Al Bailey, and he will he will be the chairperson in terms of leading the discussion on. So we welcome you all. We welcome the Medimpex team, and we led by Mr. Warren Morrison. We welcome Dr. Mark Osang, who is going to be doing the scientific session later on. And we welcome Sam and his team, and we welcome the administrator, Lynn, who puts everything together. Without her, we would not be able to put such a large meeting together. And thank you all for your attendees who are attending this evening. We thank you all because we know that you could have been somewhere else and you decided to join us. I'm sure you will have an enlightening and interesting discussion this evening in terms of whether vaccination should be mandatory and whether there should be any sanction meted out to anyone who refuses. So I'm not going to steal the thunder of the panelists. So I'm going to hand you over to Warren, Mr. Warren Morrison from Medimpex, and he's going to introduce you and tell you about the Medimpex team. Thank you. Warren?
And while Warren brings his screen up, everyone, thank you for joining. We will not be doing a pre-test and post-test tonight. So I know some of you have been asking. Thank you for all of your support, but tonight we won't be doing a pre-test and post-test. All right, Warren, so I think your screen is coming up. All right, Warren, so we're seeing your screen.
Yes. Thanks, Dr. Gordon. Good evening, ladies and gentlemen. I would like to use this opportunity on behalf of Medimpex to extend a hearty welcome to you. Thanks for inviting us into your space. This pandemic has really changed the way we conduct our activities, including having meetings like these, but having these continuing medical education seminars are very important. So despite the challenges, we press on. Thanks to the AGP led by Dr. Gordon and his team, including Administrator Mrs. Lynn Thompson Hyatt, for again partnering with us in hosting this event. And it is our intention to make this event an annual one. As you know, there are many challenges associated with conducting or having a business during a pandemic, such as the constant change in curfew times, the logistical issues, and the exposing of staff to the disease. But nevertheless, at Medimpex, we continue to strive towards satisfying and exceeding our customers' needs by offering first-class products for healthy living. You can think of products such as Cavington, Lysopress, Lodigril, and our combinations, Lysopress HCT, Lysonorm, Ramlon. I want to use this opportunity to mention to you Amlodipine. Amlodipine is a product, it's a combination of Amlodipine and atorvastatin that we are in the process of registering. And as soon as this process is complete, our hardworking medical representative team will introduce this product to you. So I now use this opportunity to introduce to you members of this hardworking and dynamic team. I coordinate a team of 8 medical representatives, and here we have, so that's me. The remainder of the team are Paul Dennis and Sasha Dixon. They work part of Kingston and Portland, St. Mary, St. Thomas, and St. Catherine. So that's Paul and Sasha. Next, we have Lisa Hubbard and Christopher Fuller. They also work part of Kingston, but their territory includes Clarendon and Manchester. That's Christopher and Lisa. And in the West, we have 2 ladies. They are based in Montego Bay, Ashley Wong and Melanie Miller. We have 2 additional reps who cover the North and the South Coast. So we have Paulette Bedward. She does primarily the North Coast, which comprise St. Mary, St. James, Trelawney, but she also does Portland and St. Thomas, parts of Kingston, St. Andrew, and parts of St. Catherine. I want to use this opportunity to introduce to you a new member of staff. She'll start the 3rd of August. Her name is Cheyenne Prendergast, and she will be covering the South Coast. So that's Clarendon, Manchester, St. Elizabeth, Westmoreland, and Hanover, also parts of Kingston, St. Catherine. So once again, ladies and gentlemen, I want to welcome you to this event. Happy that you could spend the time with us. And I'm sure you're not going to regret, especially because of the topical issues that will be discussed. Enjoy the time with us, please.
Thank you very much, Warren. Thank you for that highlight on Medimpex. Our next thing we're going to do, we're going to introduce Professor Alvastan Bailey. He's going to be chairing the discussion. So, I mean, he's going to be there to put out any fire that might be there. Dr. Alvastan, Professor Alvastan Bailey, as we all know him, he's well known to us. He's an adjunct associate professor at the University of Technology, School of Public Health and Health Technology, and he has some 40 years experience in public and occupational health and safety. He's a past president of the Medical Association of Jamaica, and he's presently chairman of the Board of Trustees. He's a fellow of the Caribbean College of Family Physicians, and in 2003, he was a recipient of the President's Award of the MAJ for outstanding achievements in the field of medicine. Since 2008, he has been the co-chair of the University Diabetes Outreach Program and has been a spokesperson on diabetes-related issues, as well as a well sought after commentator on public health. He has presented many academic papers locally and internationally, and he's also the author of a book and several training manuals in the area of his expertise. He has been the host of several radio programs on health issues. Dr. Bailey's professional life has been dedicated to health promotion and volunteerism, and he has worked closely with the Diabetes Association of Jamaica for many years. Dr. Bailey has been recently appointed to be the management of the Association of Diabetes, and he is now the new chairman of the association. Please welcome Dr. Bailey. As you can see, he's a very knowledgeable, very committed person to public health, and I am sure Dr. Bailey will do an excellent job in chairing this session. Over to you, Dr. Bailey.
Thank you very much, Mr. President. It's really a pleasure to be invited to chair this special session. And I'd like to congratulate the AGP, with whom I've worked with CCFP for many years, for putting on this session. It's a unique opportunity. I don't think I've ever had the opportunity to address over 800 colleagues before. So this really is a golden opportunity for us to meet and to interact. The topic this evening, in fact, is very current. And before I introduce your panelists, I would just like to offer a few opening remarks. As the President told you, I've spent over 40 years in occupational health and safety, and the workplace has many potential hazards: physical, chemical, biological, ergonomic, and psychosocial. But in the field of occupational health and safety, our mantra is all accidents and injuries are preventable. And so we are proactive and continue to do risk assessment to prevent adverse health outcomes using what we describe as engineering controls, administrative controls, and personal protective equipment. Now, biological hazards at the workplace have always posed a risk to workers, especially healthcare workers, carers, and members of the dental profession. But the advent of this pandemic have added a new risk, which now exposes all workers to biological hazards. And the reason for this is that this hazard is from without the workplace in most instances. Now, how can we ensure a safe workplace in these perilous times? How can we control a airborne infection at the source, along the path, and at the worker? How effective are the infection prevention control techniques that we use to stop infection? Are these just merely interim gap measures until we achieve herd immunity through widespread vaccination? Now, we are in the throes of a pandemic with rising positivity rates, increased reproductive rate, increased hospitalization, and the emergence of more transmissible and infectious variants. But we're also very vulnerable with only 6% of the population fully vaccinated. To add to this woe, we have a very protocol-averse and vaccine-hesitant population. If we do not halt community spread and bring our positivity rate down and our reproductive rate below 1, we are faced with the grim possibility of having to keep schools closed. Now, all governments around the world and employers are in an ethical quandary. When vaccines become available, should all employees at high risk of infection or transmitting the virus be required to become vaccinated, or can they decline but remain in their posts? This matter is now being debated around the world, and this seminar affords us an opportunity to analyze and critique this ethical quagmire. And hopefully, at the end of our deliberations, we will have a clearer understanding of the ethical issues we now have to grapple. And they are: should vaccinations be mandatory? Should vaccinations be voluntary? Or should we promote vaccination by making life difficult for the unvaccinated? And I want us to pause on bullet number 3, because I just heard that on the world news, that the United States of America has not implemented a law to make life difficult for the unvaccinated. And we'd like the panelists to really address that issue. We look at the news. Teachers beware, vaccinated tutors to get preferential treatment, July 27. Brownberg against teacher compensation, July 28. Teacher vax rebellion looms, July 28. Now, on July 14, France and Greece made vaccination mandatory for healthcare workers. And I was just recently advised by the president that Puerto Rico orders government workers to get vaccinated. I'd like to end my introductory remarks by quoting a statement made by Jonathan Ives, Associate Professor in Empirical Bioethics at Bristol Medical School. And he said, there is an age-old clash between respecting autonomy and respecting liberty for public or individual safety. We tend to accept in principle that we can restrict liberties for the greater good. We are very pleased this evening to have with us a distinguished panel of experts who will address these issues. Our first panelist on my list is Professor Marvin Mead, Deputy Dean Graduate Studies and Research. He's a past director of the Tropical Metabolism Research Unit, an associate lecturer in the Department of Community Health and Psychiatry at the University of the West Indies. We also have with us Sis Harris Roper. She's an attorney at law who was admitted to practice law in Jamaica in October 1997. She holds a Bachelor of Law degree from the University of the West Indies. We also have with us Mrs. Helene Davis-White. Mrs. White is president of the Jamaica Confederation of Trade Unions and General Secretary of the Jamaica Association of Local Government Officers. We also have with us Mr. O'Neill W. Grant, and he's president of the Jamaica Civil Service Association. And finally, to join us this evening, we have Mr. Winston Bradley Mafood, who is owner and managing director of Office Outlet Limited. Colleagues, we have an elite panel of experts who will address these questions. Let me remind you of the issue on the table. Should vaccination be mandatory? Should vaccination be voluntary? Or should we do, as the US is now recommending, promote vaccination by making life difficult for the unvaccinated? Let me invite Professor Reid to begin the discussion.
Thank you, Professor Bailey. All right, so I will start by getting to the chase of the matter. From my perspective, where I sit, vaccine should be mandatory for all persons for whom we have a suitable vaccine. So that's the premise on which I'll be basing a lot of my discussions and points this evening. So typically, as health professionals or public health professionals, we look at the issue of vaccination under four main considerations. Vaccine therapy is really no different from any intervention that we would propose to embark upon or propose to any of our patients, whether they be individual patients or the public at large. And broadly speaking, what we seek to do is, above all, do no harm. So within that context, what we try to do is that we try to look at the risk versus benefit. So in truth and in fact, what we're doing is a risk-benefit analysis for the intervention at hand, or the intervention that we're considering. So let's look at this situations now. I think all of us admit that COVID-19 infection is not a hoax. Well, I think all of us now recognize that there's significant mortality, that is deaths associated with COVID-19. The numbers will vary depending on countries and how you actually count those numbers. But even if you take the lowest numbers, and most people will say a number of 1% of your population, a case fatality of about 1% is reasonably a fair estimate of what it is. In some jurisdictions it's much higher, some it's much lower. That's a significant portion of the Jamaican population. So if it is that we accept the Jamaican population is somewhere in the region of about 3 million, you're probably looking at about 300,000 persons dying, right? The other consideration, of course, is morbidity. And typically morbidity is just the degree of illness that individuals may face and the degree to which you have to treat those illness. The focus most people tend to have is on direct morbidity, that is the people who are infected. But there are some indirect morbidity events that actually happen. So because of the fact that there's a finite capacity for your health system, the fact that you have to divert or pivot your health system to focus so much on COVID, it really means that there are other persons who are going to be not getting the kind of care that they actually would normally have received. And therefore, one has to balance that as well to say, we are actually increasing the consequences, the medical consequences of individuals who are not even directly affected. Separate and apart from that, the physical component, one of the things that we have now recognized is the significant mental challenges, which is sometimes very difficult to quantify in dollars and cents, or very difficult to quantify even in just numbers, and the risk associated with that. So overall, I think most people will accept that COVID-19 infection in any jurisdiction consists or creates significant morbidity and mortality and risk to the population. Then you look at what we call the socio-economic costs. So the approach that we will use is what we call suppressive measures, the public health suppressive measures. And those have significant socio-economic costs for countries and societies. Most countries actually either go into, the economy is either going into a depression or recession. And there's increased hardships on individuals all around. So those are some of the what I consider to be the challenges that we face and how we're going to fix it. Until there is really effective therapy, the main course of action is the use of vaccines. Vaccines in this case are thought to be relatively safe, and even though they're being used on the emergency use authorization. And I think a lot of people want to say, but they haven't come through the full process of clinical trials. And most people, they're rushed, and most people are using them without them being satisfying all the full traditional regulatory processes. But the issue that we face here is that even the natural experiment that is being performed now, because of the fact that we're using the vaccines, indicate that the risk of side effects is much, 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 much lower, many times much lower than the risk of the disease itself. The next consideration is, okay, if you're going to be making it mandatory, how are you going to be able to do it? How are you going to enforce it? Behavior change only occurs one of two ways. You're either going to incentivize it or you're going to punish it. We recognize that incentivization may not necessarily work because the level of vaccine hesitancy that has been reported in general communities is relatively high. And we recognize that in order for us to really benefit from the effects of vaccination, we need to reach a so-called threshold, which is called herd immunity. That proportion varies from individual in terms of the experts' opinion, but let's say on an average, most people would argue somewhere north of 80% or perhaps even as high as 90%. And with the level of vaccine hesitancy that we have, we recognize that we would never be able to reach that by an incentivization program by itself. And therefore, you have to look at, how is it that you're going to be able to have some degree of coercion to actually get there? And here is where I think the debate really should be, how do we make sure that the level of punishment that we would wish to impose is proportionate to the level of risk that we think persons would be exposed to if they accept a vaccine? Well, that I think we can debate on that, and we can work out and come to a society what that level is. But in summary, once it is that vaccines are available, and means that there is equitable distribution, or individuals have an equal opportunity to have access to the vaccine, and the vaccine has been demonstrated to be effective in your age group, and there are no medical contraindications for you to have the vaccine, it should be mandatory. And we have many public health measures that we have done using less evidence and have made them mandatory. So I close at this point, Chair.
Thank you very much, Prof. Very provocative introductory remarks. You emphasize the fact that we are back in a pandemic with high morbidity and mortality, significant socioeconomic consequence. And then you argued that vaccine should be mandatory, and you are not pushing for incentivization. But I sense from what you said, and we'll discuss that in the question and answer, that we should promote vaccination by making life difficult for the unvaccinated. So you did use the word punishment, but I think you really meant coercion. That's what you meant. But essentially, Prof. Reid's argument then, ladies and gentlemen, is that vaccines should be mandatory because of the high morbidity and mortality caused by the virus and the significant socioeconomic challenges it poses. I'll now invite Mrs. Carla and Harris Roper to join us in the discussion.
So good evening, everyone. I'm going to try and share my screen quickly for the purposes of the presentation. Okay. So I'm taking this from an employment law and industrial relations perspective. Sure that my colleagues, President Grant and President Helene Davis-White, will have a lot more to say. I have listened very carefully to Prof. Reid. Thank you very much for sharing. And certainly I don't have that much medical background. So anything that I may say, let me put the caveat that I don't have that much information that, I would expect persons of yourself, Prof. Bailey and Reid, to assist me with. So let's start from the fact that an employer by law does have a duty to provide safe workplaces. And that principle evolved from a relatively old English law case called Wilson and Clyde Cole against English. And there are 4 principles that evolved from that case. So that's what we call a common law case coming out of a decision of the court, right? So they have a duty that cannot be delegated, and they must take reasonable care to ensure that the employees are safe. So in that regard, they should provide 1, competent fellow workers, 2, a safe plant and equipment, and for our purposes, 3, a safe place of work, and a safe system of working with effective supervision. So those are the general common law principles in respect of the employer's duty to provide a safe place of work. Now, when we move on from that common law principle that came out of a case to a statute where our parliamentarians put principles in place by virtue of laws that are passed through, where a statute or a piece of legislation imposes a specific duty on employers, which is dependent on the nature of the specific type of operation, then the employers will be strictly bound by these provisions. So for example, the Factories Act of Jamaica has put in place several principles that are designed for anyone working in a factory as defined, that that employer has a strict liability to ensure that those provisions are put in place to secure workers' safety and health. Now, we do know that from our first reported case back in March of 2020, that the government has been using what we call orders or subsidiary legislation pursuant to the Disaster Risk Management Act. And for an example, I would point us to the fact that the tourism sector has been utilizing what they call the resilient corridor, and that coming under the Disaster Risk Management Act and the orders have been used to help as far as is possible to secure the safety of workers in that particular industry. Now, moving on to what we can look for on the horizon, Occupational Safety and Health Act, currently being debated in Parliament, will also impose duties in respect of safety and health in the workplace once it is that it walks through. So that is going to be an overarching legislation that deals with all industries, all undertakings. Now, I know that we have been waiting anxiously for this bit of legislation. It's taken a long time, but that should, I think, especially now that we're aware of this pandemic, embody principles that would guide and indeed mandate employers to provide safe systems of work. Now, in the context of the ongoing pandemic, an employer will have a duty to take reasonable steps to ensure as best as possible that their workplace provides a safe environment for their employees, customers, and clients. Now, how does the employer do that? What they will do, firstly, is to ensure that the guidance provided by the Ministry of Health and Wellness, as mandated under the disaster risk management orders and the protocols attached, are adhered to in the workplace settings. And we know the ones that come immediately to mind. So we talk about physical or social distancing, we're having protective devices, PPEs, masks, protective barriers, these plexiglasses we see in particular workplaces, for example, sanitization, and those should be implemented along with working arrangements, for example, to have persons working off-site, working at home, which will reduce the possible incidence of exposure in the workplace. Now, that is one avenue that can be utilized. And we can see that the disaster risk management order has also put in place particular sanctions in that regard. Also, and I'm going to spend a lot of time on this, our labor relations code actually puts guidance in place for all employers in working environments that they must put in place particular provisions to put suitable measures for worker protection and to prevent the spread of epidemic or infectious diseases. This was put in place from 1976. So we have certain principles that we are supposed to be aware of. Now, another matter is, of course, the vaccine, right? And that's where all the discussion has now moved to. Prof spoke about being accessible, and that's a very important point. Until we have widely available and universally accessible vaccine, I do not see how it is that we can start any mandate discussions. That's the first thing. Now, we hear from the last press conference, at least, I think Monday, Tuesday, that we are expecting more vaccines, and that's a good thing. But it's still, I believe, given our population is not going to be able to have the reach, certainly in the short to medium term. So we have to take that into account when we start thinking about what you can mandate. Now, when we speak about mandating, my research brought me to the Public Health Immunization Regulations of 1986 under the Public Health Act. and that relates to children being immunized. And we have gotten so used to this, you know, that we have our passport, and we have our immunization cards. And, you know, there are certain places going to daycare, to school, that the child is not going to be admitted without that. And the parents are under duty to ensure that the children get vaccinated, and that's a mandate. However, even in such a mandated legislation that we now have, there are provisions for exceptions where the child has contraindications or if they are not physically fit to be immunized. And if we take that as a point of departure, we must say, even if a mandate has come in, there are going to have to be exceptions that many of the practitioners on this forum may very well be asked to assess their patients to see whether or not they are good candidates for vaccination, and if not, provide guidance. So that's secondly. Mandate is one thing, but we must be prepared for possible exemptions based on legitimate medical reasons. And this is the part now that, you know, I will have to step back to the medical professionals. But my understanding is that there's not total immunity from contracting by having been vaccinated. My understanding, again, subject to being guided, is that you can still contract the virus even if vaccinated, and you can still transmit the virus, right? But it does provide you with a lot more protection, that your reaction to catching the virus is likely to be very much less, and the risk of death is greatly diminished. So there is that going for the vaccine. We also have our Constitution, and we talk about our Charter of Rights that has freedom of thought, freedom of conscience, protection of private and family life. So if we have this constitutional provisions that gives me that freedom, we know that it can be prescribed in terms of whether or not there are general provisions for everyone. So let's make this quick. I know we have other persons. One, if we are having new hires, we can make, in my humble opinion, make it a requirement for new hires. What that means is that it would put prospective employees on notice that this is going to be something that your employer will require, and they can make a choice at that point whether or not they're going to take a job or not take a job. They will have voluntary choice. So in a sense, even though you're mandating it, the employee will have a choice prior to taking that job. Okay? Now, when we talk about the people who are already in employment, then we have some issues to navigate. Now, if your contract of employment does not have this provision in it right now, and an employer seeks to unilaterally put that in place, there can likely be an issue, right? Because it could be considered a breach of contract. The employee may claim what we call constructive dismissal, meaning that they do not accept it and resign and then make a claim. And so every employer is going to be asked, in my mind, to be very careful about seeking to mandate this without, one, there being a government mandate in legislation that provides you with a guideline for that, and secondly, there being a contractual obligation to be able to do it. So a lot of discussion is going to be required, especially if you have a union involved, if you have a representation. To seek to do this unilaterally does open a risk. And we have started to see cases coming out of the United States and Canada where the issue of employment, testing, and vaccinations have started to come through the system. And we should likely look at those cases. I'm going to stop for now because there are other persons to speak, but I'm sure as we continue, some of the other points that I have in my presentation will come up in the discussion. Thank you for this forum.
Thank you very much, Mrs. Carla and Harris Roper. You have introduced some interesting food for thought. Your argument, therefore, is that because the vaccines are not presently universally accessible, there is no mandate or statutory provision to enforce vaccination. Professor Reed will address this question in the question and answer as to how effective really are the vaccines in terms of conferring total immunity. And will we have to get a jab every 6 months, as is being proposed in Israel? Or will we need to be immunized every year? And you mentioned the challenges that employers face with respect to new hires. That one is easy. It can become a part of condition for pre-employment. But with respect to periodic health examination and post-employment, if there's no mandate, then there's going to be a problem in terms of influencing employers' behavior with respect to taking the vaccine. But the question I'd like you to dwell upon, if the employer really believes that an employee is at risk to his fellow workers if he's not vaccinated, does he have any authority in law to make that person redundant? So you can just make a note of that, and then we will deliberate on that in a little while. I would now like to invite Mrs. Helen Davis-White to join us in the discussion. You are muted, Mrs. White. Thank you.
Are you hearing me now?
Yes, we can hear you.
Yes, I have to apologize because my internet service for the last couple of weeks have been very poor. So I'm hoping that you'll be able to hear me for most, if not all, of my presentation. To start off by saying that I agree with most of what Carla Ann has actually said. In respect to whether vaccines should be made mandatory, our view is that it should not be mandatory at this time. And I stress at this time because our view is that you cannot seek to make the vaccine mandatory in a situation where the vaccine is not readily available. I think we had an instance of an employer in Jamaica requiring workers to take the vaccine and there was no vaccine available for them to take. So it would be a little bit foolhardy at this time to mandate vaccines in a situation where they're not readily available. That's the first thing. Secondly, this vaccine is relatively new, and whereas many persons will say, you know, what they can't understand what is the problem with vaccines, and Jamaicans' unwillingness, it appears in many instances, to be vaccinated, seeing that we come from a culture of taking our children at very young ages to be vaccinated and so on. But that is what has happened in the culture growing up over several years. So our vaccination history goes way back and people are accustomed to those vaccines. What is happening now is that we have a new vaccine, and the fact that it is introduced and is being used under what is called emergency use authorization, there are many persons who are hesitant just because of that, because then comes in, what if something happens as a result of my taking the vaccine, who then is responsible? And so because of all of these things, we believe that at this point in time, it would not be wise to make it mandatory. What we believe should be the approach now is to encourage persons. So you should have various campaigns out there giving people the information and having them have the ability to question things, and for persons not to object to questions being asked, but to accept questions. And on that basis, we believe that you'll have more and more Jamaicans certainly wanting to be vaccinated. The other thing that we are looking at is that if it is that you are going into these kinds of campaigns, that you could introduce means to be able to, I don't like the use of the word coerce. It has a kind of negative connotation, but that is what ends up being at the end of the day. What can be done to encourage people to take it, whether it's denial of a benefit, denial of a service, whatever, some form of coercion. On that point, I would want to note that just as I was indicating before, that we do have a history of, our people really taking on vaccinations without much of a problem. I think the last survey that was done, we had compliance rates of close, well, in the 80% and that has been very good, and we have seen the eradication of many communicable diseases and other diseases as a result of vaccinations. But in that context, our public health regulations, the immunization regulations already have some kind of coercion kind of effect to it, because it requires children entering schools at all levels to present evidence of their having been vaccinated against various diseases that would have been noted in the regulations. And of course, importantly, the regulations also address the issue of exceptions for various reasons, which is important. So I make that point to say that if it was possible then to have developed immunization regulations against specific diseases, there's every reason to suggest that any government can amend those regulations to add whichever disease they may want to add. And in that context, the question of the information sharing is going to be even more important at this time. Once, I think we are moving to a point now where several countries, certainly the quote unquote richer countries of the world, have already started seeing their citizens, and they have vaccination rates in the 50s and so on. Once it gets to that point, I believe that the governments of the world are going to be grappling with this issue as to whether to mandate vaccinations in their particular countries. And so I believe that the Jamaican government may be having to look at that at some point in time, but certainly now would not be the time to deal with mandating vaccinations based on what I've indicated before. Coming to the workplace itself, what we usually use at the workplace to deal with workplace illnesses is the occupational safety and health regimes. So we are awaiting the passage of the Occupational Safety and Health Act, but many companies have entered into voluntary compliance with the Ministry of Labor, and so they have already started to have occupational safety and health policies and so on. The important thing about occupational safety and health, it's about ensuring that workers at the workplace that they are provided with a safe workplace. And if you do have a pandemic as we have now, to my mind, it could be dealt with under the issue of biological hazards in our current Occupational Safety and Health Act, which is now being debated. And so utilizing occupational safety and health standards is one way of being able to provide a safe workplace. And usually when you have occupational safety and health standards in any workplace, it is not a choice. Workers and employers have to observe. The important thing, I believe, in the what is being proposed in the legislation in Jamaica is that it is really tripartite in nature, and it is looking at the responsibility not only of the employer but also of the employee. And so the employer has the responsibility to ensure the safe workplace, but the employee also has a responsibility to observe the standards to ensure that not only he, the worker, is protected, but his colleagues are also protected as well. So the occupational safety and health standards and regulations would generally address ensuring that all the workers in the workplace are protected, and therefore it would not enable an individual worker to opt out because they are not comfortable. And if they do opt out, then they will know that they are likely to be sanctions that may be imposed. So I think what we have to look at really, in my estimation, is getting that Occupational Safety and Health Act passed as quickly as possible, because I believe it will address a lot of the concerns as regards COVID-19 in the workplace. Carla Ann spoke of the Labor Relations Code already, which identifies the responsibility of the employer to provide the safe working environment. But importantly, again, the Labor Code speaks to involvement of workers along with the employer in developing any such policy or regulation. And so in that context, we have had situations where, workers really don't have a choice in areas that have particular hazards, whether or not they wear their PPEs. It's a given. You have to wear your PPEs because it is there not only for your protection, but also for the protection of your colleagues. So it takes me then to the question of, in this dispensation, at this point in time, whether employers would be standing on good ground if they seek to dismiss employees who do not wish to be vaccinated, who have said clearly that they will not be vaccinated. I think Carla Ann addressed some of it. The reality is that workers work under a particular contract. And if at the time I was seeking this job, it did not require certain things, then for you to now impose it without any discussion and agreement and so on can lead to a situation of a breach of contract, and workers may be able to get remedy if an employer seeks to dismiss them for that reason. Importantly, though, were the government to put in place regulations under whether the immunization regulations or whatever other form they may want to put it in, and it requires the employer to ensure that workers meet that standard, then that now is law. I believe being able to take precedence over national law, being able to take precedence over the individual contract of employment. Just as right now, if I want to, if I'm seeking work in a food establishment, I have to observe certain requirements. I'm tested for various diseases, and if I don't meet that standard, I cannot be employed in that environment, because the law, through the regulations, the public health regulations, insist on certain things, and that is for the protection of the majority of our population. So I would say, in closing, that we are in a difficult period right now with the pandemic, but it should not be a period where persons, believe that it's fair game and anybody can do anything that they want. There are rules, there are laws that still obtain, and those should be observed as far as is possible. And what we are saying at this point in time, without enough vaccines being available, and without you're having more information, available information on the vaccine, being able to convince persons about the efficacy of the vaccine, then at this point in time, mandatory vaccination is not something that we would encourage at this time. And in fact, we would not support at all at this time. But what we would be saying to our employers and to the government, before any action is taken, that there should be proper discussion and consultation before a decision is taken as to whether we go the route of, I would not want to say mandatory, but some regime that allows persons to want to take the vaccine, whether through route of denial of benefit or by giving a reward to persons who have taken the vaccine.
Thank you very much, Mrs. Ellen Davis-White. You have presented very compelling arguments, which Professor Reid will have to defend as to why, in your opinion, the vaccine should not be mandatory. I concur with you with respect to the OSH law, which in fact has been hibernating for quite a while. And I can assure you that I would like to join you in encouraging the government to really activate that act, because that will clarify a lot of issues. Just to remind our colleagues that the AGPJ has made a record. We now have over 1,000 and more participants in this particular webinar broadcast, and it indicates to the panelists that doctors and healthcare providers are extremely interested in this particular issue, and we like to welcome all the colleagues who have joined us. Thank you very much, Mrs. Ellen Davis-White. You obviously are sympathetic to encouraging workers to take the vaccine, but you do not want to call it coercion if we have enough vaccines available. And what I gather from what you said, at this point in time, employers can't impose their will on workers if it is not in the contract. But if the government should introduce a particular mandate, then they might be able to do so. I would like to invite Mr. O'Neill Grant to join us in the debate.
Thank you, Professor Bailey. And I think the 1,000 persons registered must have to do with the fact that Mrs. Scarla and Aris Roper and Mrs. Helen Davis-White are here. And they oftentimes lay the wicket very well in relation to matters of industrial relations and the attendant things that we must observe as persons who practice the art of relationship. And relationship is what we in this movement really do pay attention to. So I want to start by framing my comments in the context of the decent work agenda and why it is that it is important that the rights of workers must not be infringed upon by any act of coercion or the threat of punishment. I smile when I say that. Decent work really is employment that respects the fundamental rights of human persons, as well as the rights of workers in terms of the conditions of work. And the conditions of work must always center around safety and remuneration to start with. We also look at this, the respect for the physical and mental integrity of the worker in the exercise of his or her employment. We recognize that the COVID-19 pandemic is impacting matters to do with work safety, and it is impacting the whole issue of remuneration because persons, for instance, who work in close proximity to persons who have been exposed to or have contracted the virus are paid a premium for exposing themselves to what we refer to as a workplace or biological hazard, as Mrs. Davis-White has indicated earlier. And we know the physical stress and the mental stress that has accompanied the workers who are working in this particular area. Now, the decent work agenda is something that we have signed on to as a country. We speak to it repeatedly. Unfortunately, Jamaica is not one of those countries that practice decent work. And for us to understand what decent work is, it speaks to job creation, that no one should be barred from their desired work due to a lack of employment opportunities. We know we're having challenge where that is concerned. It speaks to a right to rights at work, and those rights must be favorable to include days off, 8 days, 8-hour days, non-discrimination. Not because you don't take the vaccine means you must be discriminated against. The issue of living wages for them and their families and others. And of course, one of the others that I want to stress on this afternoon is the issue of social dialogue. Workers and the unions that represent them must be able to exercise workplace democracy and to negotiate their workplace conditions as well as national and international labor and development policies that will impact them in their work. Now, when we talk about COVID-19 and the hesitancy that we are seeing with where the vaccine is concerned is real. And it is all about the fact that persons are just not sure what this vaccine does or will not do. And they want the assurances from those who are the experts to tell them that this is the impact and the effect of the vaccine, and it is without a doubt. Persons have been expressing serious doubt, and unfortunately, those persons who are in the know have not been as loud in their defense of vaccination and the vaccines as those who are anti-vaccination and vaccines. Now, when we look at the law, there is no law as far as we are aware that says that the worker is mandated to take this vaccine. And we are again expressing to our colleagues who are workers that you have a right under your employment contracts not to be forced to accept an owner's contract term, which will mean imposing a new condition of employment that was not there when you took the job. Mrs. Davis-White said it, that the contract, and Callahan also said it, that the contract that one enters into at the start of the employment cannot be just changed unilaterally by the employer without violating a fundamental right of the employee to social protection and to social dialogue and to their rights at work. We recognize there is in fact obligation on the part of the employer to provide a decent and safe place for work. But what does that mean? What is the context in which we're talking about a safe workplace? Does it include persons being mandated to vaccinate themselves? We have seen many outbreaks, pandemics, and epidemics that have impacted the workplace and impacted productivity. How have we treated with those in the past? And how are we treating with the COVID-19 pandemic now? One can look and recall what happened when we had the various chikungunya virus and how it impacted the workplace and productivity. There was no vaccination as far as we could tell, but persons were asked to take the appropriate measures to protect themselves against the infection. We have the flu that impacts us every year. There is a flu injection that we can take vaccination, but not a lot of persons are being forced to take it. And as far as we are aware, the flu, and I can be corrected by the medical experts, the flu and the strains of flu that exists are oftentimes as debilitating and as morbid as the COVID-19 infection, but we are not asking persons to take the flu shot every year and mandating that they take the flu shot because of the impact it has on productivity and so on. So what asks ourselves the question, why is it that we are now contemplating mandating the taking of a vaccine that is still being tested as far as the general population of the world is concerned? We don't know the true efficacy. We are seeing the protocols changing in terms of how the vaccines must be managed. We're hearing that we are now talking about 3 shots instead of 2 and booster shots every 6 months. So the workers are saying in their minds that we don't understand and we are not yet fully clear as to what is it that we are being asked to take. And so the level of education, worker education, needs to be done to allow for the workers to be able to make a proper decision. As far as we are concerned and trade union movement, the issue of choice in this matter still resides with the employee and they should not be mandated. Mrs. Davis-White went into what could be deemed a breach of the contract, and Callahan also spoke to it, that this also could be contemplated to be a breach of the employment contract as it relates to the future. And those persons entering the workplace, I agree with Mrs. Davis-White, and agree with Callahan as well. And those persons who are entering the workplace can find themselves in a situation that if they can't prove that they have been vaccinated, may not be able to access a job, because there is no relationship that has been established between them and the employer at that stage. So the question is, do we now speak to enforcement by way of a carrot or enforcement by way of a stick? And we have seen where the Prime Minister has indicated that there is some incentivization that is being contemplated, and nothing is wrong with the employer incentivizing an employee to do something that may be outside of the regular scope of their job or the contract of employment, and incentivizing them in that respect. We have examples of incentivization that has taken place. I alluded to one earlier, where persons are working in those COVID-19 centers are being given incentives to work there. We see in other areas where workers who are working in volatile communities are paid an incentive to work in those volatile communities. So we're not saying that it can't happen. And we will actually encourage incentivization as a way of getting the workers closer, mixed with a copious dose of information and education. So I won't repeat what has been said already. We have basically gone over some of the points, and we are appearing, and when I say we, I mean Mrs. Helene Davis-White, myself, and Carla, and we appear on several programs, and we discuss the same things over, and we make the same points repeatedly. And oftentimes we start to repeat the things that we say, because we are actually looking at the perspective of what does the employer-employee relationship should look like in a situation where we have the need to maintain our employment at the current levels and to improve on the productivity that we currently now have, given our economic situation. So I will pause my comments at this point and will make myself available for any follow-up that we need to have. Thank you.
Okay, thank you very much, Mr. Grant. And in fact, I'm really looking forward to the next speaker, Mr. Mahfood, because he will be coming to us from a different perspective, from the perspective of the employer, because both Mr. Grant and the other speakers were heavily leaning towards the employee. But as Mrs. Davis-White said, that it's a tripartite arrangement, and the employer does have responsibility, but the employer also have some rights. Mr. Mahfood, tell us what your thoughts are on this matter. You're muted, sir.
Okay, thank you for that.
Good. Tell us your thoughts.
Yes, first of all, I bring greetings from the Chamber of Commerce. As you know, we're a business organization committed to building and promoting a healthy economy and improve the quality of life for our country. We think that the vaccine, the COVID vaccine, is the best response to the pandemic at this time that we have. And that's the background on which I will present our position as a chamber. So we believe that as an organization supporting and encouraging employers and employees, we believe that the things that need to be observed are the government protocols that are in place. So those are the wearing of face masks, the physical distancing guidelines, and of course, regular hand washing. So as an organization, we are supporting all of those protocols at this time. Now, given the fact that as currently stated, the legal framework does not exist for employers to probably take the type of measures that would encourage or gain traction from employees in terms of the vaccine. But if necessary, we would support amending the legislation to allow employers to create preferential arrangements for vaccinated employees if they desire. That would include also the potential to reinforce the obligation of employers that we have an obligation as employers to provide a healthy and productive work environment for diseases such as the COVID pandemic. I believe that has been stated already by previous speakers. And so that is also supported and would be carried out. But we would of course see the benefit of employing special allowances for vaccinated employees, or the testing of unvaccinated employees at regular intervals to allow access to the workplace. Of course, this isn't about precluding any employee from the opportunity to work. It's just that we want to give a greater onus on them to ensure that they're not placing anyone else at additional risk. So we also support employers providing factual and objective information that could help their employees to make informed decisions about the vaccine and to dispel, of course, any myths that exist. Because as you know, a lot of the vaccine hesitancy comes from social media. There's a lot of myths out there, and we believe that our team members need to be informed and educated so that they can make the best decision for themselves, their families, and their workplaces. So with that, we believe that, as I said, whatever protocols are stipulated by the government, we're fully in support of those, but we would also support the amendment of legislation that would give employers more latitude and to create a healthy environment, but at the same time to ensure that the welfare of everyone concerned, the overall welfare of everyone concerned, including the overall welfare, as I said, of the country, that is our overarching objective, the welfare of the country. And the fact that the vaccine is the best response at this time, we would support moves to make it easier to get available, make it easier and more available to our employees. And of course, I would, as has been said too, we at the moment are on the availability of the vaccine would prevent the uptake that we're looking for to get our country going and to reach herd immunity in a short space of time. But we can look forward to the government, as they've stated, bringing in shipments of vaccine. I've heard of possibility that maybe 300 available. There will be also, I have heard, this is unproven, that the minimum age in which people can get access to the vaccine will be lowered. It may even be removed altogether so that anyone of any age can get the vaccine. And that should really promote many more people, and also just getting the population to be more, to inoculate our population in a shorter space of time. And I look forward to any more questions that you might have after the presentations have all been made. And thank you for this opportunity.
Thank you very much, Mr. Mahfood. In fact, I'm quite pleased that you were the last speaker, because your statements will now initiate the discussion, which I'd like to first address a question to Mrs. Carla. And you said, sir, that you would like the government to promote legislation for preferential arrangement for those vaccinated. Mrs. Roper, what are your thoughts on that? Legislation for preferential arrangement for those vaccinated. And afterward, Mrs. White can chip in.
The fact remains that at this time, any employer can provide what we'd call discretionary benefits for their employees. That's the nature of it. It's discretionary, and once it is done in a rational way, there's nothing to prevent them from doing that. And if
wouldn't that be deemed to be discriminatory?
It could, dependent on how it is that it is deployed. So in general,
sorry, was that question to me? Question to.
The question I raised, Mr. Mahfood, is whether preferential arrangements for those who are vaccinated could not be deemed to be discriminatory. And Mrs. Roper was saying yes.
It could, and my own personal view is a lot will depend on the how, in how the employer goes about, exercising this discretion. But there's nothing to prevent that from happening at this point in time. And since that is the case, and if it's contractual in nature, I don't believe that there would be any necessity for a legislated response to it. That's my view.
Mrs. White?
I agree with Carla, because something like that is would be subject to the particular employer's desire, so to speak. I mean, in most workplaces, you do have allowances being paid for persons who may have particular skills. I think it could be dealt with under that heading. But the truth is, as Carla Ann indicates, a lot would be dependent on how it is actually deployed. But I don't think there's anything that could prevent an employer from deciding that they want to pay a premium to somebody for having whether a skill or, as in this particular case, for them having been vaccinated.
Mr. Grant?
Well, the issue of inducements and enticements and incentivization of workers, recognizing that they work under a hazardous situation, is something that will have to be treated delicately. Yes, it can become a matter of discrimination if it is not handled properly, because if the conditions precedent to the award of the incentive is outside of the control of individual employees, they may raise an issue that the employer is treating them unfairly, because they may in some way indicate that they would have met the conditions that would allow them to have the same allowance or incentive as the other person. So it has to be managed carefully, and the conditions precedent to the award of an incentive must be very, very clear. And it is always good to have the worker representative present at a discussion to actually pronounce on the fairness of an incentive program where that is concerned.
Thank you. Another question, another issue Mr. Mahfood raised, which I think is quite interesting, is the testing of unvaccinated employees. If you refuse to be vaccinated, then the company might request that you be tested at least twice per week. What are your thoughts, Professor Reed?
All right, so different jurisdictions have used testing protocols as a means of incentivizing individuals. While that is a reasonable strategy, my preference would be for testing protocols to be commensurate with the risk that an establishment faces, meaning that it really should be informed by those risks rather than being used as a necessarily as a coercive or incentivized methods. But nonetheless, I think if as a group or society we agree that that level of coercion is acceptable, then that's fine with me. But broadly speaking, I'm more of the view that you should use testing protocols to match your environment.
Mrs. Scala, could workers complain that they are being harassed if they are asked to be tested every week?
Well, we don't have a legislative framework that deals with harassment generally. And so it would be dependent on, again, how that is done. I think one of the issues that you may not have yet raised, which would become a part of this hostile environment. Don't know if anybody remembers the Theresa May hostile environment discourse, that by asking that an employee must be tested, and we have seen some shreds of it happening in our sister island, Antigua and Barbuda, that the test, we're not forcing you to vaccinate, but you must be tested, and the testing must be done at your expense, you, the employee's expense. That, I think, would definitely come under this hostile environment, because conceptually, PCR test, certainly in this jurisdiction, is over $20,000. And if that is a test that is being asked for, and that is going to be done in a weekly, let's say weekly, there's no, let's say the average employee is hardly going to be able to manage that. And so in essence, what you're doing, either by default or deliberately, is pushing the employee into making a determination as to whether or not they're going to want to, they need the job more, and make a decision into being vaccinated, because they simply would not be able to keep up with the testing and the cost of it. My own view, and I know I have other colleagues within the field that do not agree with me, but if you are the employer and you are saying that's part of what is going on, that you are going to be asking me or mandating that this is what I ought to do, you are the one that is mandating and asking for it. You're gonna, in my mind, should be the one to absorb that cost.
Mr. Mahfood, I'd like to respond to that. Her argument is that if I am not vaccinated, but because I might be deemed to be a risk to the fellow employees, that you would require for me to be tested regularly. The frequency will be determined by the company. Mrs. Roper is arguing that you should pay for it. What are your thoughts, sir? Mr. Mahfood?
Mr. Mahfood to be having some internet problems in and out.
Okay. What, Mr. Grant? That's the administrator. Mr. Grant, what are your thoughts? Do you think that the employer should pay for the test, or should the employee?
It's onerous. It will be onerous on the employee to have that kind of cost attached to the.
Could you stand by, Mr. Grant? Mr. Mahfood, are you back with us? Yeah. Mr. Mahfood, you're muted. All right. Yeah. The question, Mr. Mahfood, if you can hear us, is will the employer
Oh,
be?
my apologies. I'm also experiencing some internet challenges.
I understand, sir.
Yeah, my screen has been frozen that I experienced. But what I was saying is that it really is left up to each individual employer how they deal with that issue of treating with incentives or disincentives, if you may, in terms
All right.
of
We're going to pause. Mr. Mahfood is having some challenges.
gaining acceptance, vaccinated. So, hello? Okay, I'm back. I don't know why it keeps muting.
The question Mr. Mahfood was asking.
I'm going to turn off the camera. Okay, can I just say?
We can
may I go ahead now?
Yeah, please go ahead.
Okay, I don't know how much of what I said earlier was heard. Basically, it should be left up to the employer, but on the Ministry of Health and Wellness guidelines or recommendations in terms of the testing of unvaccinated employees. In terms of the cost, I think that's a tricky question, but ultimately it will be left to each individual employer how they handle it, how they would handle that aspect of the cost. Some may decide that it's at least in the short term. And of course, the situation as it changes, the dynamics of the situation will
okay, Mr. Mahfood is drifting. We're approaching 8:30. I just want to.
My apologies.
Okay, we understand.
Yeah. I don't know why I keep getting muted. I'm saying that the situation.
All right, Mr. Mahfood, you're being muted because I'm muting
I don't know
you.
why.
What's happening is that your internet bandwidth is problematic. So I'm muting you because it's coming in choppy, so that Professor Bailey can sort of move on. We're actually over our time by about 15 minutes already.
Okay.
So we'll have to move on. Apologies. Thank you.
Thank you very much, Mr. Administrator. Just want to wrap up this session by asking Professor Reid one question which came up repeatedly. The issue on the table was vaccine hesitancy because of a fear of the unknown. And there's so many unknowns, Professor Reid. Mr. Grant raised a point about how often you're arguing that vaccine should be mandatory. But suppose it turns out that the antibody response is fairly tenuous and the person needs to be vaccinated every 6 months. Or you need to get a new vaccine for every now and then for a new variant. How do you be able to defend that argument?
Sure. The short answer is that different diseases will require different protocols to maintain the level of immunity or protection that a society needs. So this is not unusual or peculiar. For some vaccines, you're required to have them every 10 years. For some, you're required to have them every year. For some, the interval is even shorter than that. So this is not an unusual phenomenon. The fact that we have to change the components of the jab has been going on for decades. The issue is because of the pandemic nature, we have what we call a time compression. And people are seeing this happening in very short period and are becoming disturbed or alarmed by it. But it's a standard or relatively well-known phenomenon in the field of medicine, where we have to make changes to maintain the immunity levels across the board. So the fact that we may have to give you additional jabs, or the fact that we may have to increase the frequency, is not in it by itself a deterrent for making it mandatory. It's just that the goal is, if we should keep our eyes on what the goal is, The goal is to get sufficient number of persons in a community vaccinated so that the risk of transmission of the disease and all its ill effect is negligible. So that's really what you're trying to do. And I think the only way you're going to get to that hump is if you assume that 50% or 40% or 30% will willingly take it, or you're going to make up for the gap that you need to get to if we accept that we are aiming for a target of 80% and more. And the way to get to that is really to make it as much mandatory as possible with enough incentive or coercive measures to get to there. I accept the fact that at this point in time, that's not an achievable target, just so because of the fact that there's an access issue. There's not enough vaccine to make that a feasible proposition, but we anticipate that we will get to that point at some point. And we understand the lag time or the lead time for legislations to go through. So the point of the matter is good for us to have a conversation now, and it's also good for us to start to put into place the necessary things so that when equity issue or access issue is not a concern, we can make the appropriate steps.
Thank you very much, Prof. I'd like to give each presenter 1 minute to wrap up their thoughts. Mrs. Roper.
This is a highly emotive issue. None the worse because we just simply, there are so many unknowns. But one thing in my mind is a known factor in our industrial relations climate is the benefit of discussion. It is the benefit of opening up the spaces for persons to have a genuine exchange of views and ideas. There are some people who will never change. There are some people who, when given an opportunity, will be able to review things. And so we should not discount the benefit of consultation. And that is something I would highly encourage your government to do in the public sector, in the private sector, where there is representation, where there is none. And in the situation where we need to get guidance, as a lawyer, I would say we may very well need to have a test case for our judiciary to help us to unravel this in the context of the various matters that we have to deal with. Until then,
Thank
all
you very
of
much,
us
Mrs. Roper.
stay safe.
Mrs. White, your parting words.
Okay, I just want to take up from a comment made by Professor Reed, which is that we have some lead time now. And I think that lead time should be used in trying to encourage as much as possible persons to want to be vaccinated by virtue of the fact that they would be provided with information, and that, as Carla Ann has indicated, that we should use this time for the consultations and the discussions so that every opportunity is given to workers and just the general population to be informed and also to take decisions based on the information that's given.
Thank you very much, Mrs. White. Mr. Grant, your parting words.
Okay. My parting words very simple. I have taken the vaccine. I chose to take the vaccine. I'm encouraging all who are here and all my public sector colleagues to consider strongly taking the vaccine. Simple.
Thank you very much, sir. Mr. Mahfood, do you have any parting words for us, sir? To unmute your mic for me, please. You unmute your mic, sir. Administrator, yes, go ahead.
We all want a healthy economy and a healthy country. And to that end, we believe in continuing to promote and support the government's protocols, and where necessary, or if necessary, to lobby the government to amend legislation so that we can have the greatest participation of our workforce and to get our country going again, to get back to where we were before.
Thank you, Prophet. I think you'll give me a parting word. So I'd like to use this opportunity on behalf of the AGPJ to thank the expert group of panelists, Professor Marvin Reed, Mrs. Carla Ann Harris Roper, Mrs. Celine Davis-White, Mr. O'Neill Grant, and Mr. Brother Mahfood for participating in this excellent discourse. This definitely is one of the most well-attended Zoom conferences. It has exceeded the number count in the participation area, so it's definitely over 1,000 and more. And the persons have not left. They have found the discussion to be gripping, and it has been quite enlightening. And as the panel said, this is the beginning of a discussion about a matter that is quite emotive, but very relevant to the health and safety of workers. I'd like to thank you all for participating, and I now hand over back to the President.
Thank you, Professor, for steering us through some choppy waters. And the panelists, they all did an excellent job in putting their point of view. And I'm sure the attendees are much more informed going forward in terms of dealing with the issues of employment or discrimination that might occur at the workplace.
One second, Dr. Gordon, if I may. Apologies to interrupt. I'm going to ask if the panelists could stay on. There's a Q&A function at the bottom of Zoom, and there are 28 questions still active. I know Prof. Marvin tried to answer a few. So if you could, please, you can just click on type answer, and you'll be able to type the answers to persons, and everyone who is participating will be able to see the answers that were typed. Thank you so much.
Thank you very much, Sam. So I know the night is going on, so I won't take up any more time. And Lisa from Medimpex, and she has some words to say to us. So I'm gonna hand you over to Lisa. Lisa Hubbard, please, your turn.
Good evening, everyone. This is Lisa Hubbard, medical representative from Medimpex Jamaica Limited, and I will be presenting on Ramlon today. And this is what I look like. For those of some of you may know me, some may not, but this is who I am. So Ramlon. Ramlon is our Ramipril Amlodipine fixed dose combination antihypertensive product. As we know, high blood pressure increases the risk for heart attack, angina, stroke, kidney failure, and peripheral artery disease. Also, it can cause development of fatty deposits in the arteries called atherosclerosis, and it can also result in heart failure due to the increased workload that high blood pressure places on the heart. Many benefits for lowering blood pressure. It can lower the incidence of stroke, myocardial infarction, and a 50% reduction in heart failure just by reducing the blood pressure in your patients. Requirements for and advantages of drug combinations. Good tolerability for components, higher efficacy than individual components, additive or potentiation synergism between components, duration of action should be greater than 24 hours, it should be applicable in the majority of hypertensive patients, and prevalence and severity of side effects should be reduced. And our Ramlon speaks to all of those. It's a fixed dose combination with Ramipril and Amlodipine. They belong to the pharmacotherapeutic group, ACE inhibitors and calcium channel blockers. So how do they work? The renin-angiotensin-aldosterone system, RAS, is a hormone system that reduces blood pressure and water fluid balance. If the system is too active, blood pressure will be too high. There are many drugs which interrupt different steps in this system to lower blood pressure, and ACEs are one of those. Ramipril, one half of Ramlon, is an ACE inhibitor. And ACE inhibitors are inhibitors of the angiotensin converting enzymes, which are often used to reduce the formation of the more potent angiotensin II, and it's one of the steps in the RAS hormone system. And with that, it results in a marked reduction in peripheral arterial resistance, and this occurs generally without any major changes in renal plasma flow and glomerular filtration rates. It also results in reduction in the supine and standing blood pressure without a compensatory rise in heart rate. ACE inhibitors is also known to improve the outcome in patients with LV dysfunction, whether or not they have symptomatic heart failure. And this is from the HOPE study. The second half of Ramlon is Amlodipine, which is a calcium channel blocker. CCBs block voltage-gated calcium channels in cardiac muscle and blood vessels. This results in several things happening. Decreased intracellular calcium, which leads to a reduction in muscle contraction, and in the heart, a decrease in cardiac contractility, and in the blood vessels, less contraction of the vascular smooth muscle, and therefore an increase in arterial diameter. Hence, the vasodilation decreases total peripheral resistance, while a decrease in cardiac contractility decreases the cardiac output. Since blood pressure is determined by cardiac output and peripheral resistance, the blood pressure drops. Also, the relaxed blood vessels allow blood flow more easily through them. This increases the supply of oxygen-rich blood to the heart and reduces the heart's workload, thereby reducing blood pressure. And here's a quick schematic of the rationale for the ACCB combination for your hypertensive patients. As you can tell, just very briefly, hypertension causes peripheral vasoconstriction, and the CCBs work to create vasodilation. This results in lowering of the blood pressure, but at the same time, this activates the RAS system again, and the ACEs work to counteract that, resulting in reduction of peripheral vascular resistance and effective blood pressure lowering with the combination therapy of the ACE and the CCB. So our Ramlon is indicated for the treatment of essential hypertension. Dosage is PO administration, swallowed whole, same time each day, regardless of food, but not with grapefruit juice. Caution is needed in patients on a diuretic as fluid and/or salt depletion may occur. Dosage in special populations. For renal impairment, recommended only for patients who were switched to the 2.5 or 5 milligram strengths as the optimal maintenance dose of ramipril. Renal function and potassium levels should be monitored during treatment. Elderly and pediatric, not recommended for the frail and old or under 18 years. Contraindications. Angioedema, second and third trimester of pregnancy, definitely not recommended in the first trimester. Hypotensive and hemodynamically unstable patients, cardiogenic shock, obstruction of the tract of the left ventricle, and hypersensitivity of any of the ingredients. Adverse side effects, some of the common ones, 1 in 100 patients. Blood potassium can increase, you can get headache, dizziness, somnolence, palpitations, hypotension, orthostatic blood pressure decrease. Can also have non-productive tickling cough, bronchitis, sinusitis, GI inflammation, abdominal discomfort, dyspepsia. Maculopapular rash, muscle spasms, ankle swelling, edema, fatigue are some of the adverse effects that can happen with Ramlon. So as we can see, Ramlon does hit the target for many of the hypertensive patients. It has a wide range of presentations. It's a true long-acting ACCB fixed dose combination. Synergistic effects. It has a complementary selective cardiac and arterial mechanism of action. Cardio and renal protection from both agents. Potential side effects from one agent is countered by mechanism of action of the other. Low prevalence of side effects because of this. Not likely to increase glucose levels, not likely to cause sexual dysfunction, reduced risk of ankle edema, and reduced risk of tachycardia. It's also especially good for your isolated systolic hypertensive patients or your diabetic patients with uncontrolled hypertension. And it has compelling indications for a complete range of hypertensives with micro or macrovascular and metabolic complications. Ramlon comes in 3 presentations, 5.5, 10.5, and 10.10. And the package size is 30. With NHF, it costs approximately 2,200 to 2,500 for a pack of 30. Please consider it for your moderate to severe hypertensive patients, your diabetic patients, and your systolic isolated hypertensive patients. Thank you for your attention and for all your support throughout the years. And we look forward to our continued partnership. Have a wonderful evening. Good night.
Thank you very much, Lisa, for that excellent discourse on Ramlan. As we move into the second session, we're going to hand you over to Christopher Fuller, who will introduce the guest speaker tonight. Mr. Fuller, could you please take charge, please, sir?
Thank you, Dr. Gordon. And yes, I'm Christopher Fuller, medical representative with Medimpex, and I take pleasure in introducing to all of you, noted Jamaican, certainly one who is not unfamiliar to most of you, Dr. Mark Hosang. Just to highlight a few things from his CV, Dr. Hosang received a DM in internal medicine from the University of the West Indies in 2005. And then in 2009, from the University of Toronto, he received a cardiology fellowship. And from 2009 until the present, he has been a consultant cardiologist at the University of the West Indies in the Department of Medicine. He's also a member of the Junior Students Curriculum Committee and the Cardiovascular Week Planning Committee. He has 2 private practices that he operates out of, one located at the Winchester Business Complex and the other at Portmore Hospital Complex. Dr. Hosang also has interests in teaching and enjoys teaching both post and undergraduate students. So we would love to hear from you, Dr. Hosang, as you address us on hypertension, what is the target, and how to get there. We eagerly anticipate your presentation, Dr.
Hosang. Thank you, Mr. Morrison and Medimpex, for inviting me to be a part of your symposium. I have to say that this is probably the largest audience I've ever presented for. I'll just share my screen here. Okay, so this evening, for those of you who remain, we'll be talking about hypertension, a topic that's pretty common amongst all of us and something that most of us should be familiar with dealing with in one way or the other. And I'll be talking about what are the targets and how to get there. A very brief overview of what I would recommend that everyone do and how to go about evaluating these patients. So hypertension is very prevalent in the world. In our little island, we have data coming from our epidemiology unit from Ferguson et al. From the Jamaica Health and Lifestyle Study 3, which is the most recent one, which looked at data from various clinics over the island between 2016 to 2017. And according to the original definition of blood pressure of 140/90 and above to be considered to be hypertension, which is the old GNC 7 guidelines, it was estimated that 34% of the Jamaican population have hypertension. With the newer ACC 2017 guidelines, which I'll speak a little bit about, using the cutoff of 130/80, then that in prevalence went up to 58%. It's estimated that about 60 million people in the US are hypertensive, and it's not just a number when we think about hypertension, but it's the significance really is the complications that arise and the associated end organ damage that occurs with prolonged uncontrolled hypertension. It's also, for most of us who are in clinical practice, either general practitioners or internists or cardiologists, is probably one of the more common reasons for adult office visits, especially in a general practice. And it is one of the highest, it represents the highest usage of prescription drugs. And it's also important to note that the control, we've not been doing a very good job, because a good portion of patients don't actually recognize that they have hypertension. And those who are recognized as having hypertension, many of them are not being treated. And for even those who are being treated, only about 50% of them are achieving what we would consider a fair degree of control. So as we can see, it's a problem that affects many people. It's a significant portion of our population, over a third, depending on your definition, to over a half, based on the definition from the American College of Cardiology, which was published in 2017. And it is associated with significant morbidity and mortality, as well as significant costs to the health system, as well as to the patients, personally, financially, and socially. I mentioned earlier that target organ damage is one of the things that we really have to focus on. And when we speak about target organ damage, the main organs that we are focused on are the brain, the heart, the eyes, kidneys, as well as the peripheral vessels. And I'm sure most of us are familiar with what the complications are in these different areas, being for the brain, being stroke, transient ischemic attacks, dementia, early dementia. And for the heart, we get left ventricular hypertrophy, congestive heart failure, coronary artery disease, and a multitude of arrhythmias, probably the most common being atrial fibrillation. For the eyes, retinopathy is not an uncommon complication of hypertensive heart disease, and it is often overlooked in many patients because many physicians don't, as a routine, do fundoscopy, and especially in the new COVID era, we've actually been recommending that fundoscopy not be done as common because of the proximity with which it brings you in contact with the patients. Because to do fundoscopy, you have to get really up and close to the patient, and therefore very close to respiratory or droplets. So in a COVID era, doing fundoscopy, you have to take extreme precautions, and probably only if you really, really need to do it. Peripheral vascular disease, especially that of peripheral arterial disease, to make the separation from peripheral venous disease, is also quite common and causes quite a bit of business for the vascular surgeon. So quite a number of things that we get from complications with target organ damage, which results not just in mortality, but also in morbidity, because in my opinion, there are many things that are worse than death. And having a stroke or dementia are some of those things, as well as the debility that may occur in somebody who has heart failure or arrhythmias or end-stage renal disease, where they have to go for dialysis on a regular basis, whether hemodialysis or peritoneal dialysis, taking time out of their day, and many are unable to work as a result of that. So not only is it costing you money, but it's also preventing you from making money in the long term. So there are significant financial and medical implications of this disease. So when we talk about hypertension, one of the first things that we have to do is to be able to recognize it. And it's good to have an idea as to what it is that we need to do to make that diagnosis of hypertension. It's important to note that in the vast majority of cases, you're not going to be able to make a diagnosis of hypertension just on a single visit with one blood pressure reading. You'll usually need to have about 2 to 3 office visits separated by a 1 to 4 week interval where you'll measure their blood pressure. When they do come to the office, you should do 3 measurements separated by 1 minute intervals and average out the last 2 measurements. Okay. If you get a blood pressure on a single visit of 180 over 110 or above, and especially if there's evidence of cardiovascular disease, then I think that is sufficient to diagnose that patient with hypertension. So you don't need to bring them back at any other interval and you can initiate treatment right at that time to prevent any progression of or to reduce the progression of their disease. And on the other side of that is if your blood pressure is less than 130/85 with a single reading, then clearly that patient is not hypertensive, because that is a nice normal blood pressure. It's also important to note that sometimes it can be very difficult just to make a diagnosis of hypertension from office measurements, as there are people who have what we call white coat hypertension, where their blood pressures may be high when they come into the office, but on a regular basis, when they're at home or when they're in other settings, their blood pressure is seen to be normal. And one of the best ways to tease that out is to do a home blood pressure monitoring, where they can do their own monitoring at home using an approved device, or by using ambulatory blood pressure monitoring, usually a 24-hour blood pressure monitor, which is usually available in certain specialist centers or certain offices. Most cardiologists, inclusive of myself, will offer this service of ambulatory blood pressure for those patients who there is an issue with trying to make the diagnosis for these patients. And we'll speak a little bit more about that shortly. So this little cartoon gives you an idea as to what the basic setup is for your patients. And I'm sure that most of you know this who are in clinical practice. You want to have the patient seated, make sure they're well supported, make sure that their legs aren't crossed so that both feet, the soles of both feet, are flat on the floor. Have a cuff that is of an appropriate size, which will fit the arm, whether it is small, a normal size, or large. And there are usually markings on the cuff that will let you know exactly if it fits within the recommended range. And it's also recommended that you not talk to the patient while you're doing the measurement, as that may cause an elevation of their blood pressure. And of course, you want the room to be quiet. You don't want anything to be exciting the patient. They should be comfortable. And you don't want them to either have any coffee or smoke or exercise within 30 minutes prior, or not wanting to pee right at the time when you are doing their blood pressure, because one can imagine the urge to micturate while doing your blood pressure can cause a somewhat elevation of your blood pressure. And it's funny, but in my office, sometimes patients, they come in for their appointments. They might come a little bit early, or I may be running a little bit behind time. And so they've been sitting down in the waiting room for a little while. And then right as I call them, they go, excuse me, doc, but where's your bathroom? And funny enough, they've been waiting for about 30 minutes or so. And it's only as you call them that they realize that they have to go relieve themselves. Of course, you have to give them the chance to do what they need to do. And so they can come into the office and relax for a good, 3 to 5 minute interval. Usually during that time, we would have a little talk about what it is, the reason for their presenting, if they're a new patient, or any follow-up questions to their previous complaints if they're a review patient. Because you should have them try to relax and do your best to make them comfortable in your office for at least 3 to 5 minutes prior to doing your measurements. As I mentioned before, you should do about 3 measurements and average out the last 2. Okay. So I mentioned earlier about the different definitions of hypertension, comparing JNC's 7 guidelines, which is an older guideline, versus the ACC AHA update, which was in 2017. And there are other different societies which also have their own definitions for hypertension. There's a Cardiac Society, there's the International Society for Hypertension, there's the European Society of Cardiology, and in England you have the NICE guidelines. So there are a number of different societies, and they all have their own thoughts on how hypertension should be managed. So what I've tried to do is to distill a lot of what's out there and the different recommendations from the different societies and organizations, and try to highlight some of the important points and maybe some of the more controversial points, so that we can kind of work it through. So in 2017, prior to 2017, with JNC 7, hypertension was kind of recognized as a blood pressure of 140/90 or greater. However, in 2017, the AHA decided that they were going to shake things up a bit and to change the classification of blood pressure, as well as some of the pharmacologic recommendations with emphasis on cardiovascular disease. They also eliminated the group of pre-hypertension, which was seen with a lot of the JNC guidelines prior to that. They also focused on accurate measurement as well as on self-monitoring and some of the different treatment recommendations. And a lot of this stemmed from a trial called the SPRINT trial, which was probably published a year or two prior to that, which had shown that there was some benefit in lowering the blood pressure, even lower than the previous levels that we had considered as being a standard of care. So what the AHA did was that they now reclassified the blood pressures, and they called 120, less than 120/80 to be a normal blood pressure. And then they got rid of the pre-hypertension group, which was previously, like 120/139 and 80/89. And they divided it up now into an elevated blood pressure if you have a systolic of 120/129. And of course, the diastolic remains the same as in the normal group of less than 80. So the real thing that really, caused quite a stir amongst the profession was the classification of stage 1 hypertension of being 130/139 and diastolic of 80/89, because this previously would have fallen under that pre-hypertension group where, you wouldn't normally be as aggressive in trying to treat them at that stage. And stage 2 is our usual, or what most of us will think about when we acknowledge someone as being hypertensive, as having a systolic blood pressure of 140 or above, or a diastolic blood pressure of 90 or above. So this caused quite a bit of confusion, because then people began wondering, well, what do we do if, are we going to start treating everybody if your blood pressure is 135/85, and what to do with it? So it was, quite controversial when these kind of guidelines came out. And what the AHA said, however, was that, you didn't really have to treat everybody who they classified as stage 1 hypertension in that 130/139 group, or the 80/89 millimeter mercury group. What they recommended, however, was that in these patients, once they're assessed as having stage 1 hypertension, that you would assess their 10-year risk. And this is using the Ascvd calculator, which is a cardiovascular disease risk calculator, which was designed and later validated by the American Heart Association. Or if they have known disease, so if you have known cardiovascular disease, or if you're diabetic, which is seen as a coronary equivalent, or if you have chronic kidney disease, then it was seen that these patients you should initiate treatment in these patients, which is actually quite similar to previous guidelines. I mean, if we looked at things like the Diabetes Association guidelines for hypertension, patients, the Diabetic Association was recommending treatment to less than 130/80 in their diabetic patients, even from before all of this. So it really, even though it does sound different, it really is not that big a change or a divergence from what other organizations were recommending from before. And in terms of treatment, it is recommended that lifestyle changes be a part of it, what we call TLC, or therapeutic lifestyle changes. Should always be a part of any treatment regime for hypertension. So they recommend TLC or lifestyle changes and initiation of one blood pressure lowering medication or antihypertensive in this group of patients with stage 1 hypertension, because your blood pressure is not that high, so really you just want them to come down just a little bit more than they were previously. And then you would be recommended to bring them back in a month, and then every month thereafter until the blood pressure has achieved satisfactory control. So less than 130/80 would be what that would be considered. For the patients who have stage 2 hypertension as determined by the American Heart Association, which is what most of us will think about when we think hypertension, to 140/90 and above. Again, healthy lifestyle changes and blood pressure lowering medication. But at this point in time, it's usually recommended that you would initiate 2 drugs to get them. And 2 drugs, usually in a single pill combination, and at the lower end of the dosing range. So you start them off in a fairly low dose. And this is really to enhance the efficacy of the drugs by the synergistic action of drugs. So you would have to use drugs from different classes, and we'll speak about that shortly, and which drugs we would recommend as being first line. So 2 drugs would be the recommendation at a low dose for stage 2. And in patients who are quote unquote black patients, then the drugs that you'd want to use would be thiazide-like diuretics, as well as calcium channel blockers, preferably the dihydropyridine calcium channel blockers, which includes amlodipine and nifedipine, to name a few. So to contrast that, so the next year, the European Society for Cardiology, or the European Society for Hypertension, they also published their guidelines in terms of what their definitions for hypertension were based on the home, both based on office, ambulatory, and home blood pressure levels. So the office blood pressure, again, so 140/90 is kind of what they would still consider to be hypertension. So as you can see, there's no clear consensus among the different organizations as to what you want to call it. And really, it's just a lot of semantics, because like in the AHA, they're not going to start treating you unless your risk is high. And also with the ESC, they're also, if they're going to treat you, if you're seen as high risk based on their different scoring systems, then you will also be treated to a level of less than 130/80. But according to their definition, an office blood pressure of 140/90 or above would be considered to be hypertension. They also made notes of the role of ambulatory blood pressure monitoring and home blood pressure monitoring, which I had spoken about briefly before. I'll start off with home blood pressure monitoring, because that is probably something that most of us are familiar with. And the values for somebody with a home blood pressure monitor would be 135/85 or above. So please note that when you have your patients doing their home monitoring, that your thresholds are going to be a little lower, that of 135/85. In some patients who you want to confirm the diagnosis of hypertension, who claim that their blood pressure is normal outside of your office setting, you may want to send them for a 24-hour blood pressure monitor, otherwise known as ambulatory blood pressure monitoring. And this essentially is just really a portable blood pressure device where they would go into the office, we'd put it on, the device would inflate every half an hour during the recognized awake time, and then probably about every hour during the sleep time, which would be programmed prior to the device being put on based on what the usual sleep and wake patterns of that patient is. So it's noted that the daytime mean would be 135/85, but the nighttime pressures would be 120/70, which is one of the advantages of having ambulatory blood pressure monitoring, that you can actually see what your blood pressure goes to or does not go to during sleep. And then the overall mean blood pressure would be seen as 135, one greater than or equal to 130/80 if you're looking at the mean. So if you exceed those targets, then you would be considered to be hypertensive. And the ambulatory blood pressure has a much greater sensitivity and specificity for hypertension, as well as being able to differentiate between white coat hypertension masked hypertension, as well as patients who have lack of nocturnal dipping, which is where your blood pressure fails to fall as it should at nighttime, because you notice that the nighttime thresholds are low. I'd said this just not long ago. Ambulatory blood pressure monitoring, it has a certain amount of advantages. White coat hypertension, you're quite familiar with, and then masked hypertension is kind of like the reverse of that, where your blood pressure is actually normal in the office and high outside the office in the regular day. And this may be due to patients who are taking medications, who are known hypertensive, but who may not be fully controlled at times outside the office, because they may take medications in the morning, and by the time they're in your office, it's much higher, or it may be due to other factors like smoking or other stresses in the workplace. Ambulatory blood pressure monitoring has a greatest prognostic value amongst all the methods of blood pressure monitoring, whether office or home blood pressure monitoring, and also allows you nighttime measurements, which none of the others allow you to do. The main disadvantages, I think, are pretty obvious. It's going to cost you more if you have to go and do this test. It's not available everywhere. And it can also be a little bit uncomfortable to have something inflating on your arm every half an hour and then every hour when you're trying to sleep. Because I have patients every now and then who will complain that they have difficulty sleeping because of this thing that is on their arm. Home blood pressure monitor measurements has its place as well. And it's something that I also use quite widely, and probably much more so than the ambulatory BP, even though it is available in my office. It has a number of advantages, being, again, identified as white coat versus masked hypertension, but it's also much cheaper. It's easier to get. You can get it in most health supply stores or even pharmacies. At home, it's a more relaxed setting. It allows the patient to be more engaged in their care and can be done over a much longer period of time to show actual day-to-day variation, as opposed to a one-time or a one-visit measurement during the office, or a 24-hour period where you look at it only for one day. So it shows day-to-day variation, and over a much longer period of time. Of course, the disadvantages are that you're only doing your blood pressure once or twice for the day. It doesn't allow you to check on your blood pressure during the nighttime. And there's also a potential for measurement error, whether due to patient or operator related issues. They're putting on the cuff wrong, or maybe the cuff that they have is the wrong size for their arm, more so a problem for the larger sized individuals. And also some of the machines that are used may not be validated. And there are sites that the American Heart Association has put out to show you which machines they recognize as being validated devices, because not every device is created equal. And also to note that it is for arm measurements, so not the wrist monitors, because the wrist monitors are notorious for being inaccurate. And also the measurement of blood pressure becomes less accurate the further away you go from the heart. So there are also physiological reasons as to why that might be so. So once you've diagnosed hypertension, you need to seriously start considering initiating treatment. It's important that the choice that you use is very consistent, because a lot of patients who are hypertensive, so this graph is showing the nighttime or morning surge amongst patients who are known hypertensive, who are not treated. And what it's showing is that the number of patients do have what's called a morning surge. So in about 6 in the morning till about 11 o'clock in the late morning, it can be seen that there is a surge in their blood pressure. And this is thought to be due to a number of neurohormonal influences related to cortisol and activation of the autonomic nervous system. And so we know that your blood pressure does go up during that period of time, and this increase seems to correlate fairly well with the timing of both myocardial infarctions or heart attacks and stroke. So this next graph also shows that the frequency of stroke also goes up during that same morning time between 6 a.m. and 11 a.m. where an acute myocardial infarction is noted to be up to 3 times more common over that period of time. And strokes occur, 44% of them occur in this morning period. So having a medication that you might take in the morning, but that doesn't last you a full 24 hours is really going to leave you exposed to a lot of these risks here and won't give you full coverage. So therefore, your risk reduction is not as much as it could be. Okay. And prior to initiating treatment, there are a number of things that you want to go through with as a part of initiating treatment, I should probably say. A part of it is to establish key bits of information from your patient, because it's not just about medication, but it's also about lifestyle changes. And in order to trigger someone to have a lifestyle change, it's important to understand what their lifestyle is in the first place. So, things like family and personal history of hypertension and other target organ damage gives you an idea as to their level of risk. And then you also have to look at other family or personal history of other risk factors, such as hyperlipidemia. You need to check if they smoke. I think most of us will ask all of these questions, but also to give an idea of their diet, including salt as well as alcohol consumption, and their level of exercise. Okay. A history of erectile dysfunction is important because up to over 70% of patients who have hypertension do experience some degree of erectile dysfunction, because hypertension causes accelerated atherosclerosis, and the very mechanism of having an erection is that of increased blood flow. So any disease that will reduce blood flow to any area will automatically cause erectile dysfunction as a part of the complication. So, you need to express this to a lot of men because they do complain. One of the frequent complaints is that, they don't want to be started on drugs because it's going to kill their nature. It's important for them to understand that if you don't control your hypertension, that's also going to kill your nature. And unlike drugs, which usually there may be an initial effect on the erectile function, it is usually transient for most patients. Once you have atherosclerotic disease, that atherosclerotic plaque is not going anywhere. So your erectile dysfunction is going to be for life. And, no man wants to be going around being called deadwood because that is a bad thing, generally speaking. Also important to note are other things like evidence of sleep apnea. So you need to ask about snoring, if they snore, if they have observed apneic spells, and also how well they sleep, if they feel well rested in the morning. And a lot of this has to be derived from the partner because, as you might guess, most people don't know if they're snoring because they're asleep at the time. It's also important to note, especially for women, if they had hypertension in pregnancy or preeclampsia, which does have a significant risk of progressing to the regular chronic hypertension in the future. Even if their blood pressure does return to normal after the pregnancy, there is a much increased risk of progressing to hypertension. It's important to evaluate your patients fully, not just with a history, but also recommending necessary investigations. It's important to do the urea and electrolytes, the BUN and the creatinine. Here it's important to see if what your sodium and potassium levels, to look for things like hypoaldosteronism, other secondary causes, as well as your potassium and your sodium is important because many of the drugs that we use may have effects on these electrolytes. The creatinine is important because renal dysfunction is known to be a secondary cause of hypertension, but also hypertension in and of itself may cause renal dysfunction. So having a baseline level of the patient's renal function is very important. Also being able to establish other risk factors for cardiovascular disease, such as hyperlipidemia and diabetes, by doing their lipids, their fasting blood glucose, and their HbA1c are all very valuable baseline laboratory investigations. Urinalysis is also important, more from the standpoint of being able to detect proteinuria. And it's a very quick, easy test to do. It's very cheap. And it's important to be able to establish upfront if they have evidence of proteinuria, because even with a normal creatinine, that is evidence of renal involvement, and the choice of your medications will be directed based on the presence of proteinuria or not, because certain medications are more indicated for that reason. And ECG is also essential as a part of your baseline, because you want to establish that this patient is, or have documentation that this patient is in sinus rhythm at the time when you're seeing them. Also, look for evidence of other target organ damage, such as left ventricular hypertrophy, ischemia, or any other prior myocardial infarction, which may lead to downstream investigations. Speaking of downstream investigations, I mean, we have to look at the different organs for the brain, and these other investigations that are listed on this slide are not what I would consider routine investigations, except for fundoscopy and except for the urine albumin, the urine albumin creatinine ratio. Urea albumin creatinine ratio. So if you think that somebody has had a stroke or a TIA, or if they're suffering from dementia in the presence of hypertension, an MRI may be involved, may be indicated. If you think that somebody has an arrhythmia or ischemia or prior infarct, an echocardiogram would definitely be in the cards. A urea albumin creatinine ratio enables you to determine if there is any proteinuria in these patients. That's important to establish straight off the bat. So usually, at some point in time for my hypertensive patients, I will order this test. In terms of the arteries for peripheral arterial disease, you might want to look at the carotids, doing intimal medial thickness. Usually for patients, however, who you might have detected a carotid artery bruit, on examination of the patient, you would send them for an IMT, or patients who have had a stroke. You might also want to do carotid Dopplers or intimal medial thickness. To look at the aorta, you can do pulse wave velocity, not so common these days, or if you think that they have peripheral arterial disease, an ankle brachial index would be indicated. So that would be indicated if they have a history of claudication, so calf pain on walking certain distances, or even rest pain of the calf, or if on examination you are able to detect a decrease in their peripheral pulses, for example, the dorsalis pedis or the posterior tibial, or even the popliteal pulse. If you have noted a reduction in any of those, then an ankle brachial index may be also indicated. And fundoscopy, I think we spoke about it before, to look for evidence of hypertensive retinopathy, which at its extreme end will give you exudates, hemorrhages, as well as papilledema in the 4th stage. So treatment, we've kind of touched on this earlier, kind of an introduction. TLC stands for therapeutic lifestyle changes, and pharmacology, I think that's self-explanatory. So in terms of treatment of hypertension, less than 50% of hypertensive patients are actually on treatment. And treatment is very effective, because if you can lower their blood pressure by 20 systolic or 10 diastolic, then that's associated with a 50% reduction in their cardiovascular risk. And we only are achieving this target in less than half of our patients. One of the main barriers of control of hypertension and achieving our targets is that of adherence. And adherence is essential. And notice I've written that in red, because that's something that we often overlook. And just to give you an example, often when I do ward rounds in the hospital, when I'm covering the cardiology service, we come among many patients who are hypertensive. And often the story goes, okay, Dr. Hosang, this is a 64-year-old gentleman. He has a 10-year history of hypertension, but he has been non-compliant, and he presents with shortness of breath, swelling of the feet, orthopnea, PND, etc. And you say, okay, fine. You go on to the next bed, you go, okay, there's a 50-year-old man with a history of hypertension who's non-compliant, who presented with shortness of breath, swelling of the feet, orthopnea, etc. And there was one ward round that I went to, and there were 3 histories that were very similar, all men, of course, and all with a history of long-standing hypertension, well recognized, but who were all non-compliant and who all ended up with heart failure as a reason for their admission to the hospital at that time. So it's one thing to say, well, you know, we're going to try and give you all these drugs, but if they don't adhere, then it all goes to no benefit. And it's known that non-adherence is a poor prognostic indicator, and for obvious reasons. However, it's important to understand why patients don't adhere to therapy. Oftentimes when my junior staff, they talk to me about these cases with heart failure, and they talk about the non-compliance or the non-adherence, they often gloss over it. And my first question is usually, why? Why is it that they're not taking their medication? And there are a multitude of reasons for that. It could be due to the healthcare system. Maybe they don't have access to a doctor where they are. They probably might live in the country. The doctor doesn't come in so often. They can't get an appointment, or they tried and whatever, or you know, the health center is too far for them to get there because of where they live. It might be due to the medications that are used. They might not agree with it. It might be too many tablets is what they frequently complain of, because the patients all say, oh, doc, I don't want to take any tablets. You know, I don't like to take tablets. Well, you know, most of us don't. Most people don't want to take tablets of any kind for any particular reason, even in the short term. And having to take multiple tablets multiple times per day is always going to impact on adherence. Okay, as well as, of course, side effects of the medications will also impact on that. And of course, socioeconomic status. Some people just can't afford the medications. You know, I usually do tend to prefer a lot of the branded drugs, because you're definitely sure what you're going to get. And with generics, you know that generics have a more lax kind of requirements in order for them to be considered as such. And they're not really required to have even 90% of the efficacy of a brand drug. I mean, you can get much less than that and still be considered a reputable generic. So normally I prescribe brand, but not everybody can prescribe can do the brand, and many of our Jamaican patients will need to be on generics, and will also need to ensure that they're on the National Health Fund. So, and it's funny that I still come upon patients who have chronic diseases who they've never been offered the form for the National Health Fund to be filled out, which is surprising to me every time I come across it. So also a reminder, please fill out that National Health Fund form for your patients when you recognize or when you first diagnose them with a chronic illness. Okay. I spoke about TLC, and this is the usual thing that you guys know: salt reduction, eat a healthy diet, you know, nuts, unsaturated fats. Moderate alcohol use is recommended, 2 drinks for men, 1 drink for women, because alcohol, even though has some benefits in the reduction of cardiovascular risk, it's a J-shaped curve. So once you start going above a certain level of recommendations, then you're going to actually cause an increase in your blood pressure and a subsequent increase in the downstream effects of complications and target organ damage. Weight reduction is important. Usually that weight reduction starts in the kitchen. So that is very important. Smoking cessation, physical activity, the usual 150 minutes of aerobic activity per week, and 2 days a week of resistance training, which we often don't emphasize or mention to the patients. But also important is stress reduction. And I think that in today's day and age, stress reduction has become even more important as a part of our daily lives, and not just for hypertensive patients, but I think generally people, everybody, and especially in the COVID era, we're seeing a lot of stress-related diseases A lot of anxiety and depression has become quite prevalent ever since we have gone into COVID. And there are a multitude of reasons for that, which I won't get into. But definitely stress reduction is important, not just for hypertensive patients, but for all people, and has been associated with falls in blood pressure. Things like meditation, yoga, or other mindfulness exercises, which they can always YouTube it if they so desire, are useful, but not to be underemphasized. But stress reduction is important. When it comes to the pharmacological treatment of these patients, we need to think about the type of drugs that we use, and we need to have in our mind what would be that ideal drug. So, it should be a drug that's proven to work. If a drug is not really proven to work, then it's kind of sketchy why you're prescribing that drug in the first place. Preferably, it should be once a day, because nobody wants to take drugs twice a day. Nobody wants to have to remember to take a drug in the evening. Nobody really wants that. It should be affordable. It should be cost effective. It should be affordable or cost effective, because even though a drug may be somewhat expensive, it may be considered cost effective in the long term if you are going to reduce things like hospitalization or even doctor's visits, etc., and other forms of downstream testing. It should clearly be well tolerated. All those men who complain of erectile dysfunction, you can understand why that would be so and why they wouldn't take their medications. And there should also be evidence of benefit in the population it is to be applied. So not every drug will act the same in every single population. And some of the guidelines have kind of stressed that for different populations, being the patients who are self-recognized as being Black as having more benefit from calcium channel blockers, for example. So there are certain drugs that we would consider as our preferential drugs to start. These are the ACE inhibitors, ARBs, calcium channel blockers, preferably dihydropyridine group, amlodipine, nifedipine, and diuretics. So diuretics, I'm not referring to loop diuretics, well, not as a first line, but the thiazide-like diuretics. So thiazides are like your hydrochlorothiazide, which are the drugs that I'm not actually referring to, because those drugs have actually not been shown in the studies. Those were not the drugs used in the studies to show the maximal benefit. The diuretics that have been shown to improve morbidity and mortality are chlorthalidone and indapamide primarily. Okay, so those other drugs that are often in combination. Oh, sorry, there's a hand. Oh, okay. Right. So these are the diuretics that are proven to be of benefits. So those four in some form of 2-pill combination, noting that you would not combine ACE inhibitors and ARBs in the same patient, because that would increase the risk of hyperkalemia as well as azotemia. So I'll show you that in my next slide. But also you want to consider spironolactone for those patients as kind of a third-line drug, or fourth line, as the case may be, for patients with resistant hypertension. Beta blockers are not first line and are really only used for patients who may have a compelling indication, such as coronary artery disease, arrhythmias such as atrial fibrillation, or heart failure. Other alternatives are like your alpha blockers and your vasodilators, doxazosine, hydralazine, etc. So usually when we're starting, we'd usually start off, as I'd mentioned before, with a low dose 2-pill combination. ANC stands for angiotensin converting the RAS blockers. So either your ACE inhibitors or your ARBs, combine it with a calcium channel blocker. So those are a good first line. But I mean, you can also use your diuretics as a part of that combination. The next step would be to go up on the dose. So if you bring them back in a month, you haven't achieved your blood pressure control. And remember, it should be a month that you bring them in. So don't bring them back in 6 months, because of the half-life of these drugs. Usually you'll see the maximal effect in about a month. So you don't want them to be out of control any longer than is necessary. So step 2, when you bring them back, would be to gradually titrate up the medication till you achieve the full dose of that 2-drug combination. Step 3 would be addition of a third drug. Usually this would be your diuretic if it was not used before, and there are combinations where you can use a diuretic before. And remember, the diuretic is preferably chlorothalidone or indapamide. However, you can use drugs like hydrochlorothiazide if that is found to be, you know, a cheaper alternative or a more accessible alternative, depending on your patient profile. And step 4, usually by the time you reach step 4, you should be considering referring these patients to a specialist, whether a cardiologist, an internist, or a nephrologist would be the usual specialists that you would consider. And with step 4, you'll consider that resistant hypertension, where you're on 3 drugs, one of which would include a diuretic without having achieved your target. Spironolactone would probably be your next best option after that. But usually at that point, you would consider referring that patient on for further management. So some considerations when initiating therapy. You have to be careful with certain patients. You don't want to start them off on 2 drugs. You want to use 1 if they're found to be a grade 1 hypertension, according to the AHA guidelines. So if you're 130 to 139 or 80 to 89, then you don't want to have them on 2 drugs. So monotherapy is quite adequate unless they're found to be high risk with other evidence of target organ damage. Also, the elderly patients or the very frail patients, you have to be very careful, because these patients are more prone to hypotension and sometimes do not tolerate even normal blood pressures very well. And sometimes with the elderly patients, especially those above the age of 80, you might want to consider being a little bit looser with their control, allowing them to have systolics up to, or at least raising your ceiling to about 150 for these patients because of the risk of hypotension. So you're a little bit looser with that very elderly group. In patients who are quote unquote black, you should consider calcium channel blockers as a first line in combination with either diuretic, ACE inhibitor, or an ARB. And if you do decide to add spironolactone for your resistant patients, please be careful to note what their GFR is, as well as the level of their potassium, because of the contraindications with this drug. Beta blockers, as mentioned, are not first line. They're more like 4th or 5th line, but unless there is a direct indication for it, such as heart failure with reduced ejection fraction, angina, post-myocardial infarction, if you have atrial fibrillation or some other supraventricular arrhythmia, pardon me, or if it's a younger woman who with thoughts of future pregnancy, because especially in those patients, you don't want them to be on ACE inhibitors or ARBs because of the contraindication with pregnancy. Just a quick note on fixed dose combinations. There's definitely a benefit, because they've done meta-analyses of studies that have shown the level of compliance with either dose compliance or timing compliance in patients who have to take more than 1 medication. So this is a meta-analysis by Claxon et al. Between 1986 to 2000. 76 studies were used, and they looked at 2 categories of dose taking and dose timing, and they looked at the compliance of both things. And what they showed was that the mean dose compliance was about 71%. If you only had to take 1 drug for the day, your compliance was 79% in average. If you're taking 2 drugs a day, it was 69%. And going up to 4 doses a day, it went down to 51%. So you can see that the number of tablets that you have to take per day, whether of the same tablet or of different medications, your compliance is going to go down in terms of dose. And dose compliance meaning if you miss any doses. So the more doses you miss is the less dose compliant you'll be. And then timing compliance has to do with if you take your medications at the recommended time or at the proposed time that was agreed on before. And it was seen that mean dose timing compliance also was about 59% in these patients, but it was associated with lower compliance when you have more doses for the day. So we recognize that the more doses a day, the less compliant you are. But there's also evidence that if you can pack these drugs all into one pill, then they're more likely to be compliant and therefore control their comorbidity, their chronic illness. Here we have, again, a meta-analysis that looked at 68 studies. However, only 9 were able to fulfill the inclusion criteria. And basically what it says was that in these patients who are hypertensive, by using a fixed dose combination, they were able to reduce non-compliance by 24%. Okay, which is where most of the recommendations come from in using a fixed dose combination as opposed to the individual components. Not to necessarily say that you're wrong for using individual components, because you may have to use individual components of these medications in certain patients because of availability, because of cost, because a lot of these fixed dose combinations, especially those from branded houses, can run you a pretty penny, and it's often cheaper to provide the individual constituents of that drug, because one, they're cheaper from the get-go, and also because they're more available in like the NHF pharmacies, where they're given at minimal to no cost at all to the patient, versus the branded drugs. Okay, so a part of your target in achieving your goals is that you should assess adherence every time your patient comes to the office. And there are a number of ways you can do this, and we won't get into it too deeply, but the easiest way is to just ask, are you taking your medication? And you should be able to foster a relationship with your patient so that they should feel free to tell you things. So, you know, don't become so very accusatory when you're talking to the patient, you know, and berate them and treat them like a bad person. It's important to understand, you know, that they be open, that they be honest with you to tell you whether they're actually taking it or not, because it's important for you to know and for you to actually understand why it is that they do that, because most people are not truly bad people, and they're not doing it just because out of spite for you. So there's never any reason to take it personally. But it's important to understand why they do it. Other ways of addressing adherence include things like the prescription, how many times a prescription has been filled over the course of the time. Because if they've been away for 3 months and they have 2 months worth of prescription left, when you look at the old prescription, when the pharmacist signs it up, you can say, well, you missed a few visits to the pharmacy. Also to do things like pill counting, to look at the containers, which will fall more into the domain of the caregivers to actually do all of that, because those are very time-consuming processes to actually count out tablets to assess how many should be out of or how many should remain in the container based on the time at which it was bought. So this is my final slide. So just in summary, proper measurement is essentially making a diagnosis. It will either lead to overdiagnosis and over-treatment of patients, or under-diagnosis and under-treatment of the patients, leading to further complications, or over-treatment leading to side effects of medications that would be unnecessary. It's important to evaluate for target organ damage, and we kind of set out to do this by history, by examination, as well as by investigations. And if you're going to start for patients who are diagnosed with hypertension, then a single pill combination would be the preferred choice, yet not the only choice. There are reasons for doing other ways, and there's more than one way to skin a cat. And when you see a patient whose blood pressure is not controlled, it's important to consider non-adherence being a cause, and to kind of speak very candidly to the patient and say, well, you know, are you really taking your medication, or are you just telling me these things to make me feel happy and not cuss you out in the office? It's also important to note the value of out-of-office blood pressure measurements, whether home blood pressure readings or ambulatory blood pressure monitoring. And what I do routinely is that I will often tell my patients, so anybody I have in my office who's hypertensive, I would strongly recommend that they have an automated device. I usually recommend Omron, because there are many other devices out there, but I can only remember one name at any time. and Omron is one of the recommended ones. And to do their blood pressure a week prior to coming in, and have it done twice a day during that week to look at diurnal variation as well as day-to-day variation in the patients. And then base that and then correlate that with the in-office measurements. Also in resistant patients, you might want to think about obstructive sleep apnea. When they're not responding, please ask about snoring and how well they're resting. And then NSAIDs, because a lot of our older patients, they have often different painful or arthritic complaints, and they may be on NSAIDs, which are enhancing or preventing us from achieving our goals in these hypertensive patients. Please be very cautious in the elderly. Don't try to drop their blood pressure to 120 or 70. Many of them are not going to tolerate it, especially if they've been hypertensive for multiple years, where there's a process of autoregulation in your brain. They'll just straight up faint on you. And to understand that lower targets should be for high-risk patients, anybody with cardiovascular disease, any patient with renal disease, any patient with diabetes should have a lower target of 130/80. So that's my last slide, and that's all I really have to say. So I would like to invite any questions from the audience at this point in time.
Thank you so much for your presentation. Wonderful, very well received. We have a few questions here. Let me get right into them. First is from Alagina Baker. Hopefully I'm saying the name correctly. Is HTN any contribution to a first-degree heart block?
So a lot of cases with first-degree AV block, they kind of happen on their own and just kind of due to degeneration of the system. There is probably some relationship between the two, but not necessarily so. First-degree AV block on its own doesn't usually require treatment, so it's something that we know to be there, but we don't necessarily have to initiate any treatment for first-degree AV block. But it's important to note that patients with first-degree AV block do have a small increased risk of going on to develop atrial fibrillation and needing a pacemaker in the future. So in and of itself doesn't require treatment, but it does prompt you to become more alert to future complications.
Thank you so much. Is telmisartan a good happy lowering drug?
Sure. So telmisartan's a pretty good drug. It's pretty good for blood pressure. It belongs to the angiotensin receptor blocker class, and they work. It works. Telmisartan's pretty good. It has a pretty good 24-hour blood pressure profile, which we do recommend for our patients, because you don't want them to be exposed to that late night surge or the early morning surge. And also to add that often you may need to give some of your medications at nights so that their maximal effect prevents that surge. Can zinc supplements raise blood pressure? To be honest with you, I'm not sure, Dion. I'm not really sure about that, to be very honest with you.
Can taking pill at night mitigate early morning surge?
Yes. Right. So I just mentioned that a little while ago. So yes, taking the pills at night can mitigate the early morning surge, especially depending on the type of drugs that you're using. So if you have a drug that they might be on for whatever reason, and it doesn't necessarily give you that great 24-hour coverage, you might want to consider taking the medications at night. And in fact, personally, I have been recommending my patients taking their medications at night, especially those patients who are on amlodipine with whatever combination, because the nighttime dosing of amlodipine has been associated with reduced side effects such as the peripheral edema.
Awesome. I see after commencing therapy with single pill combination, is it possible to discharge patient from the meds once the pressure is controlled?
Okay, that's a good question, and that's something that comes up quite a bit with a lot of doctors. So it's important to understand that hypertension is a chronic illness. So this is a lifelong illness, and there's no cure for it. And usually the best that we can hope for is really just control. There are, however, instances where patients are able to change their lifestyle significantly to the point where they no longer need to be on medication. Usually those are patients with just mild hypertension or stage 1 hypertension. They cut out salt in their diet and they stop drinking alcohol, they lose weight, they're exercising. And those patients sometimes in the exceptional case do go on to need less or even to come off medications. However, once initiating therapy, usually once they're controlled, we're very happy with that, and we will continue therapy unless there are side effects from the therapy that would require us to reconsider that option. So usually once started on the therapy with a single pill combination, we usually just continue them if there are no other contraindications. So in order for us to change that stance, it would have to be a problem with a side effect of one of those medications, or probably an issue with cost or something of that sort. Or if you notice that they're now going hypotensive on the single pill combination, then that stance would have to be reevaluated. And in those exceptions, it's exception, not the rule, we can consider maybe de-escalation of the therapy. In the past, hydrochlorothiazide was said to be good in Black populations. Do you think it does currently, or will you prefer thiazide-like use instead? So hydrochlorothiazide is good in the Black, is good in the quote-unquote Black population. Just for the record, I don't officially recognize terms such as Black people and white people, but that's a side note. But yes, in the quote Black population, it is still effective. So even the thiazides like hydrochlorothiazide are effective, but I still do prefer the thiazide-like diuretics, because the thiazide-like diuretics are the ones with the evidence for benefit in morbidity and mortality. And these drugs have also been shown to have less an effect on the metabolic profile. So one of the side effects of thiazide diuretics is that they tend to cause hyperglycemia, as well as other things like hyperuricemia. So the metabolic profile of the thiazide-like diuretics, such as indapamide, tends to be, generally speaking, a little bit better. Also hypercalcemia, also tends to be better than the thiazide diuretics themselves. Some of the drug reps will want to tell you that they don't see that in these patients, but I've seen it. I mean, I've used the thiazide-like diuretics, and I've seen that too. So it happens in both, but I think from what I'm made to understand, and in my small experience, the thiazide-like diuretics tend to cause a little bit less of some of these other metabolic side effects. But it's still a good drug. It can still be used. There's nothing wrong with you using it in today's world, and it's probably cheaper than some of the other combinations, and it's very difficult to get chlorthalidone here in Jamaica. I think there may be a combination with it. Indapamide is probably more accessible. Single dose.
Doc, thank you so much. We're way over. I'm gonna ask you, please, if you could you're seeing the questions in the Q&A. If you could just click on type answer.
Sure.
You could answer those last 3 questions that are there. We appreciate it. And now I'm going to hand over to Melanie Miller. She's from the MedImpacts team, and she'll be doing the vote of thanks.
Our most valued invited guests, ladies and gentlemen, good evening to you all. It gives me immense pleasure to deliver the vote of thanks for this webinar. No event can happen without the provision of a vast network of people. This event was able to take place with the collaborative efforts of MedImpacts Jamaica Limited and the Association of General Practitioners of Jamaica. I, on behalf of Medimpex Jamaica Limited and the entire AGPJ body, extend a very hearty heart of thanks to all speakers for gracing us with their presence and contribution to make this webinar a great success. To our panelists, Professor Alvastan Bailey, Professor Marvin Reed, Mrs. Carla Ann Harris Roper, Mrs. Helene Davis White, Mr. O'Neill Grant, and Mr. Bradley Mahfood. Thank you all for an enlightening and interesting discussion on a very sensitive topic, COVID-19 vaccination in the workplace. I must mention our deep sense of appreciation for hearing the varying perspectives on this topic from the array of professional background of the panelists. We have all garnered more information from this discussion that may later aid in addressing matters surrounding this topic. I also wish to express our sincere thanks to Dr. Mark Husang for giving an excellent coverage on hypertension. As hypertension continues to be a major chronic disease amongst the population, it is even more crucial to stress the importance of having blood pressure being controlled during the pandemic. Ladies and gentlemen, an event like this cannot happen overnight. The wheels started rolling weeks ago. It required planning and a bird's eye for details. We have been fortunate enough to have been supported by a team of very motivated and dedicated colleagues from the AGPJ under the leadership of Dr. Donald Gordon, our moderator. A special thanks to Mrs. Lynn Thompson-Hyatt, administrator of the AGPJ, for her immense support to make this webinar a success. A big thank you to Mr. Samuel Heron, the technical support specialist, for ensuring the smooth operation of the online platform from start to finish. Ladies and gentlemen in the audience, thank you all for choosing to be with us. It is an honor for us that you opted to be here. It has been a great pleasure. Thank you all and good night.